Welcome back. Today, we're continuing the conversation around adult ADHD. This will be our fourth episode that we've made about ADHD, and I'm very pleased to welcome back Dr. Russell Ramsay to the podcast. Dr. Ramsay is a co-founder of the Penn Adult ADHD Treatment and Research Program in the US, and he served as professor of clinical psychology in the Department of Psychiatry of the Perelman School of Medicine at the University of Pennsylvania. He's the author of Non-Medication Treatments for Adult ADHD, CBT for Adult ADHD, and the Adult ADHD Toolkit. His most recent book is called Rethinking Adult ADHD, and that was released in 2020. In addition, he has a popular blog on Psychology Today. The first episode we recorded back in February 2024 was an episode all about what it's like to have ADHD, what the diagnostic process involves, what kind of impairments ADHD can cause. Today we focus a lot on treatment, what a diagnosis of ADHD means, how a patient can consider whether or not they should take medication for ADHD, psychological interventions like cognitive behavior therapy, and the difference between applying cognitive behavior therapy for things like depression or anxiety and applying them for ADHD. We specifically drill down on how individuals with ADHD can think about things like focus, time organization, task completion, and procrastination. We discuss some of the controversy around the ADHD diagnosis and whether or not it could be being overdiagnosed or underdiagnosed, whether or not ADHD is a disability or a difference, and whether or not social media is a useful forum for people to learn more about ADHD. Just a couple of updates on my end. My latest Guardian article came out last week, and that's an article discussing things like intuition and decision making and whether or not we can follow our gut instinct. So I'll put a link to that in the description. And I will be speaking at the TEDx conference at the London Business School, and that's taking place on 28th of April. Myself and many other interesting speakers will be giving short talks, and this year's theme is Beyond Boundaries. So again, that's taking place on the 28th of April, and tickets are publicly available. So I'll also put a link to that in the description. And if you'd be interested in having me speak to your team or organization about subjects related to psychology or mental health, you can email me at alexcurmitherapy@gmail.com and put speaking inquiry in the subject line. As always, there are many ways you can support the podcast. And the more supports we get, and as the listenership grows, that means we can continue to make a better and better podcast, get better guests, improve our production quality, and so on. If you'd like to support it, the best ways are by sharing it, giving us a rating, giving us some sort of review wherever you watch or listen, and checking out some of the links in the description. As always, thank you for listening. And now here's today's conversation with Dr. Russell Ramsay. Russell, thank you so much for coming back and continuing this conversation with me.
Alex, you're very generous. Thanks for having me. Glad to be here. It was a great time last time, and I'm expecting great things again today.
So just starting off, what does it mean to have ADHD? If you diagnose someone and they say, what is ADHD? What do you tell them?
How I describe it is, and this may be a bit of a repeat from last time, but I'll just start off even with the name, attention deficit hyperactivity disorder, and it's a list of 18 symptoms. And they're pretty good, but it's incomplete. Like ADHD is not really an attention deficit. It's more of an attention allocation problem. So this sort of starts the discussion of the nuance and hopefully geared towards the person's experience. But I'll talk about the attention allocation problem. And some of these are analogies, metaphors used within the field that, borrow from others, and hopefully they borrow from me. ADHD is more of a performance problem than a knowledge problem. Most people say, I know exactly what I need to do, but I have a hard time doing it or organizing it, or I come up with great plans, but I don't follow them. So these examples, I think, resonate for a lot of people rather than, and these are not wrong, being distracted, being restless, or being impulsive. And very often people will be forthcoming with their stories, either, oh yes, that sounds like me, or other things. So it gets at, in a way, I'm going to borrow a line from, one of my early mentors saying that, there's no cognitive therapy for depression. the cognitive therapy treats the problems of depression, the low energy, the not doing things, the whatever it may be. That's really what we target. And I think cognitive behavioral therapy for adult ADHD is very similar insofar as we're probably not treating the core symptoms, but we're treating the executive functioning difficulties, the time management, the disorganization, the motivational issues. So this sort of explanation with clients, how we make sense of ADHD so that we can understand it and it helps with the evaluation, but also bringing it back, it gives the targets, the real world targets for treatment that are probably why people have sought us out in the first place. And I just want to make clear that medication treatment, I'm a psychologist. I do not prescribe. I cannot prescribe. But I have a great respect for what psychiatry can bring to the table for treating adults with ADHD or anybody with ADHD. And, by targeting the symptoms, that can be very helpful. I like how Steve Ferrone and Kevin Antshell, they differentiated between narrow band treatments and broadband treatments. So medications would be considered a broadband treatment. You treat the symptoms of ADHD that it has these broad positive effects. Just like getting corrective lenses, eyeglass lenses, can help with reading, but might help with other things like driving, other things. And CBT numbers among the narrowband treatments, very specific targeted treatments like academic accommodations or educational support services. ADHD coaching would fall into that realm, but so does cognitive behavioral therapy, where it's focusing on the day-to-day functioning. Now, just because it's within the narrow band, those can be very broad band treatments because it's really what we're all about is how we spend ourselves, what we do with ourselves. And, going back to see, you're getting the academic answer to a very straightforward question, but it's, part of, and what is so insidious about ADHD, it's doing the things that, not only the things we have to do as responsible adults, but also the things that we want to do, be it for well-being or self-care. And, that's really the focus of a lot of the psychosocial treatments is overall well-being, but that's insidiously what ADHD gets in the way of.
Yeah, and that last point you mentioned, I think, is really important. Many people who criticize ADHD as a diagnosis would say, don't we all struggle with these things? Don't we all struggle with, doing the things we kind of have to do, the mundane things to get on in life? There's an argument to be made there that, people with ADHD really suffer with doing those mundane things, perhaps to a level that other people simply don't. But then also, I think an even more powerful argument, as you just pointed out, is people with ADHD have a really hard time actualizing their desires, their passions. They, for example, would love to learn the guitar, but they just can't do, doing anything to a high level, enjoyable or not, requires a certain amount of tedium and dedication. That might be doing the scales when you're playing guitar or just showing up to practice every day. And I hear that, when I see people with ADHD, it's not just that they can't do their taxes, that there are very real things, their hobbies, or even, spending time with their children or doing things which require a little bit of patience, which they really struggle with. And often they seek treatment to help with those very things.
Right. Including following through with healthcare recommendations, physical therapy, a medication regimen like antibiotic or whatnot. I worked with a client who was diagnosed with Lyme disease, but was very inconsistent in the antibiotic treatment, which extended the illness longer than they wanted to. And you mentioned something about, don't we all have ADHD? And based on some research, and it's nothing new, but it's a way to answer those critiques to say, well, yeah, in a way, a case could be made that not that everybody has a little ADHD, but the difficulties are not unfamiliar. But the study I used to cite that dimensionality of ADHD, like when we think about it in self-regulation or that executive functioning model, these are standard human factory settings. We all have the executive functions. The impulse control, that's part of what makes us human, being able to stop and pause and motivate ourselves for things that we don't want to do. So everybody has this capacity. But it was a study of children. It was a population study. I forget the country. It might have been the Netherlands, but Don't quote me on that. But it was children rated by their parents. I think they were about 8 years old. And so the parent, based on parent ratings, and they identified whatever percentage in the group was diagnosed with ADHD, but it was a broad population, healthcare population. And so parents rated their children both on the 18 symptoms of ADHD and their sense of quality of life of their child. And it turned out to be a smooth dimensionality. So many children were rated as no symptoms or maybe one symptom, and they had the higher quality of life ratings, again, based on parent ratings. As the parent ratings of symptoms went up, 4, 5, 8, 10, all 18, there was a steady drop in parents' rating of quality of life. So that is the definition of dimensionality. With some medical conditions, there'll be some cliff for blood pressure or some other measure where, once the blood pressure reaches that, or obesity or whatever the case may be, there's a quantum shift. But this dimensionality, and this is important clinically, one, it's a way to give a non-defensive, you're right, everybody, this is why it seems like everybody has a little ADHD, because the problems are not unfamiliar. We all procrastinate at times. We all forget things. We run late, whatever the case may be, but it's a matter of degree, just like with vision, weight. There are many health matters where it's dimensional, and at some point it becomes problematic, or if you will, diagnosable, or even more so, disordered. So ADHD is one of those conditions, but it's, I think Edmund Burke said it more eloquently than this. It's hard to tell when day turns into night, but it most definitely happens. And I stole that from Ned Hallowell and John Rady in Driven to Distraction. But it's important clinically because there could be subthreshold presentations of ADHD causing many problems. But if somebody's like 1 or 2 symptoms short of the diagnosis, it's not like, oh, no, this isn't diabetes, we don't need to do anything. It's like, well, that could be, and that's unfair because there could be, borderline diabetes. So that's not the best example. But here with ADHD, there might be a situation where somebody goes, you don't have all the symptoms, but there's no better explanation. But this is consistent with ADHD, but you might just have a subthreshold case.
Yeah, and I see a lot of those subthreshold cases. So I think really important to point out wonderful metaphor about dementia, the dimensionality. And of course, we see this with all sorts of physical and mental health conditions. Most people know what it's like to be sad. Most people know what it's like to have low mood for a few days, and for that to be associated with like some kind of sleep change or appetite change or energy change. But then depression is a categorical difference. We've had many conversations on the podcast recently about what might be the underlying cause of depression, biological, psychosocial. But regardless, in terms of the patient's experience, you can argue there's a categorical shift where things go off a cliff edge, as you said. Once someone has a diagnosis of ADHD, I assume you said you don't prescribe medication because you're a psychologist, but I imagine people ask you questions about whether or not they should consider taking medication. And from what I can tell in the ADHD world, some clinicians kind of fall into the camp of someone gets a diagnosis, therefore medication is kind of automatically recommended. And I think some clinicians would say, actually, it's more of a personal choice. It's kind of contextual, depending on what's happening with the patient at that moment. When people ask you questions, about whether or not they should consider medication, how do you counsel them?
Right. And you gave some excellent examples. I start with right of self-determination. If you believe in it, you're going to be more likely to do it. And with the medications, though, if people ask, I'll say, you know what? One, they are highly effective and taken as prescribed, safe, among the most effective and the safest we have in clinical psychiatry. Now, that being said, they're medications. It's a big deal. And, being clinicians, I can speak, hey, statistically, no greater risk for addiction than anybody else, if not even some studies saying it might be somewhat protective. But that's why we get a family history, or somebody has a history of abusing stimulants. The probably the most effective medication class for ADHD, that for that person, that is crucially important, or a health matter. I've had some clients who, for medical reasons or due to pregnancy or breastfeeding, chose either were medically contraindicated or chose not to do it. So right of self-determination. Now, that said, going back to it being a viable option, I'll say, you know what, if you have questions, I mean, I can answer some based on research or, side effects or profiles or whatever, but not definitively. But I remind people, and again, I can be, like I tell my clients, I can spend your money quite easily, but you could go in and meet with a prescribing psychiatrist or other prescribing physician and be handed a prescription, but you're not mandated to fill it. And you could go in and get the recommendations, ask questions, personalizing the treatment. But, even if you walk out with a prescription, you're not mandated to treat it. It's information. And some people, and they'll ask, well, what's the best combination? And, there are many cases where, medications alone, just like eyeglasses, not to minimize it at all, but some people say, once I got on the right medications, how one person described it to me when he got started on prescribed stimulants was, it buys me time. I notice the distractions. I still hear them, but I'm not automatically pulled away. I can stay focused and continue, or, before I'm about to go away from something, come back. Now, again, it's not magic. You can still procrastinate, be disorganized, run late. And, sometimes that's people's experience. They can focus better, but they're still having executive functioning problems. So sometimes the addition of the psychosocial treatment after starting medications alone, and vice versa. Some people say, let me try cognitive behavioral therapy or, any other non-medical treatment by itself for a while and see how it goes. And there's, some evidence of CBT for adult ADHD, where one group was started with combined cognitive behavioral therapy and medications for ADHD. And another group either was, I think all but one person never took a medication for ADHD, and one other person did a 6-month washout. Both got better at the end of the 12 weeks of treatment, but the medicated group got better, more better than the non-medicated group. But I think it was 3 and 6 month follow-up, then there were no significant differences between the groups. So it took the non-medicated group maybe longer to establish, the coping habits or whatever the case may be. Now, one study, I don't want to oversell it, but it's seeing how there are options if somebody doesn't want to take medications or doesn't respond, can't tolerate the side effects, or maybe has a medical condition that makes it, contraindicated. So, all options are on the table. But, in terms of going through, I review it as an option, the evidence, but also, reinforcing, personal choice, but also, medical evaluation, just to make sure there's not contraindications.
Yeah. And I think that's really interesting. I didn't know about that study. It's interesting. It reflects how I often counsel ADHD patients about the difference between non-medication strategies and medication, and that I normally frame it as non-medication strategies take a lot more work up front, but they may, their effect may be more sustainable, may last longer, like 5 years, 10 years, 15 years. Medication may work a lot faster. And I think, like you said, I think it's a viable option, but I do worry about its longevity.
Yeah.
And I think the main reason I worry about its longevity, and you can correct me if I have any of this wrong, is I think most of the research about ADHD medication is conducted on roughly a 2-year time horizon. And that means, of course, that doesn't necessarily mean that ADHD medications don't work beyond the 2-year time horizon, but it might mean that the effects may start to wear off. It may mean that side effects increase. People may have to switch between medications. Some people may stop medications altogether. Again, that doesn't mean taking medication is a bad idea. And I think anecdotally, a lot of people report that it was still good to have a period of time on medication. It helped them in lots of different ways. That could be to help them put non-medication strategies in place, or even to get the sense of, like, I now have a sense of what it's like to be not distracted. So I have an idea of what mental state to shoot for. And then lurking in the background is some ideas around neuroplasticity, meaning could taking ADHD medication for a period of time, could it change the brain in some way? And this, it should be said, is speculation, hasn't really been scientifically demonstrated as far as I'm aware. But that's kind of how I frame them. Non-medication strategies, harder, slower to put into place, but may have more longevity, and medication kind of the opposite. What do you think about that?
No, these are, especially with the hypotheses about all the things and, nobody's going to fund the study. Hey, let's follow this group for 30 years on medications and see, compare and contrast, even though that's in a way what we need. And some people will, stay on them. And everything you say is very, reasonable and well thought out and clinically indicated and good information to share and ways, things to contemplate. One thing I'll add to that is some of the just published within the last year or two, Margaret Sibley is the first author as part of a larger group and part of the MTA study, the largest study of combined and individual medication and psychosocial treatment for children back from the 90s that they're still doing follow-up studies on, tracking them over time. Now, this was about the diagnosis of ADHD and tracking the symptoms from childhood through adolescence to young adulthood, mid-20s. And this does apply, hopefully. And what they did is, and they had the group without ADHD and did follow-up evaluations just to see, do people catch ADHD later on? But also the children with ADHD tracked over time to the mid-20s. And what they found was, the broader takeaway, the children diagnosed with ADHD, there was, I think, a 91% persistence between the starting time and the end time. Now, within that persistence, there were some that were persistent every time, but very often there was a certain percentage. I forget the exact number. It might have been in the 30%. It was either in the 36% range or like the 60% range. But at some follow-ups, they would be sub-threshold for a while. So maybe at age 12, or let me bump it up, maybe at age 15, they didn't meet the full criteria. But then again, at 19 and 25, they did something like that. And it's more conjecture about what might explain it, even though it seemed like it wasn't like it was totally gone. It might be sub-threshold or below a certain threshold. And it's not like it's cyclical, but part of the hypotheses about what's going on is that at certain times, at least based on just, I think, anecdotal accounts from the people going through the evaluations, is maybe there's some threshold of busyness where this, between school and maybe work or other things, the schedule becomes, in that sweet spot, scheduled enough that you have to do things that if you don't do them, if you don't study after work or something like that, you fall apart, but not so busy that it's overwhelming or lacking busyness that it's hard to get motivated. So even how a persistent presentation of ADHD can go up and down over time, but projecting that into the future about going on and off medications or even going in or in and out of cognitive behavioral therapy, because I have many clients who will come back periodically for booster sessions or after a few years. There may be certain environmental setups, like getting at a job that works for you, that over time you build up the habits for managing the job, or a family situation. There's a scaffolding that is more ADHD friendly. Not that everything is better all the time, but it can be a lot better where somebody goes, I'm on top of this. I have ways, the accountant takes care of my taxes nowadays, and it's much more manageable, maybe without active treatments at time. But, another voice I've heard about the maintenance of treatment, though, is, if you're not in treatment, and this is more specific about the medications, there may be some risk. I can't cite a chapter or verse of a study, but there would be some concerns about some of the long-term effects, like on, managing health and some of these things, which is a problem for everybody. Again, going back to the dimensionality. But, that would be some of the concerns maybe voiced about ADHD. But again, right of self-determination, that's where clinically, any individual circumstance might be, hey, I'm doing well. I'll call you if I need you, but I'm doing well on my own right now.
Yeah, absolutely. I always tell patients they're in the driver's seat when it comes to ADHD. And the good thing about ADHD, in contrast to other conditions you could name, there's a lot of things you can do. There's nothing that you have to do. So they do have, people with ADHD do have the luxury of choice, so they can pick and choose different interventions at different times of their lives, as you say, that suit them, that suit the particular difficulties or challenges they're facing. I think it's interesting what you mentioned about the cyclicality of symptoms, that they can wax and wane with time. I have seen that clinically, from some of the ages you described. I think between 12 and 20, I would wonder about puberty. If part of ADHD is like impulse control, I'd wonder about the effect of testosterone in a young man, and hyperactivity, of course. And in the female population, what I hear reported again and again is, yes, I think I've always had these kinds of ADHD symptoms, but when I hit menopause, wow, did they get amplified? So that, especially as female ADHD in women is getting more recognized, this is something we're seeing more and more in the clinic.
Right. And senior adults with ADHD at the same time. And Sandra Kooi, Kooj in the Netherlands, and many of her colleagues too, they're doing a lot of groundbreaking work on perimenopause and menopause in women. And actually, while I was at the University of Pennsylvania, a colleague, Kay Neal Epperson, and she is at the University of Colorado now and a leader in women's health. There was also a study that she collaborated with Dr. Tom Brown on, of the Brown Attention Deficit Disorder Scales, and world-renowned ADHD expert, looking at women without a history of ADHD who in menopause started having features of it. Now, they did not have the neurodevelopmental syndrome of ADHD. I get what you're talking about there. It could be many adults who say, oh, I never thought I had ADHD until 30, 40, 50, maybe even 60 and beyond at sometimes. But these would be women without any history of ADHD, but going through perimenopause and menopause, felt like it, and they found that they did a study using a prescribed medication for ADHD and found that these women had benefits from it. So it's sort of a reverse, a circumstance where it's not ADHD, but there's a lot of similarities where an ADHD medication was helpful.
Right. Okay. So now diving deeper into non-medication strategies, a patient may choose medication or choose to disregard it. But regardless of that, if someone then comes to you and they say, okay, I want to know, what are the most important non-medication strategies I should consider to manage this? How would you advise them?
Clinically, it would be sort of like what they're looking for. Is it academics, work, whatever it may be. But broadly, in terms of evidence support, medications and cognitive behavioral therapy are the two most well evidence supported. Now, there's a lot of, just like there's probably a lot of medications being studied or being developed, there's a lot more psychosocial needs, because generally the cognitive behavioral therapy has been either individual or in group settings, has been very helpful, and that gives a lot of flexibility. But, things like adult ADHD coaching have a growing evidence support. There are some emerging approaches looking for couples and family members with ADHD, both the partner with ADHD and the non-ADHD partner. So there's a variety of things that aren't yet too well developed, where they're out there, but obviously meeting needs. And as Steve Ferrone would remind me, president of the World Federation of ADHD and overall good guy on top of that, and very widely published and knows what he's talking about, but said, even being evidence-based, we can admit, hey, here's something that might be helpful, but there's no support for it yet. That's where, some of the mindfulness-based interventions for ADHD are at. They have some support, and these can be helpful on various fronts. Now, some of the ones that people bring up commonly, neurofeedback training, that's one where there's not enough clear-cut positive evidence of it being effective more than placebo. Some studies, yes, some studies, no, but it's generally not out there. I don't hear as much about it anymore myself, but some of the other ones that are available, but maybe harder to study, like academic support and academic accommodations. Now, actually, with the academic support, that's one of those where ADHD coaching and dealing with college students with academics, some of the growing research support for it, that's where it comes from, even though there are some other studies looking at adults. And again, some more studies in the queue and developing. There are things like exercise, especially aerobic exercise, that there's research saying that it can be helpful. Some, one, the overall health benefits, but also some short-term, time-limited benefits on attention and some of the other features of ADHD. But I'm not sure, and maybe it's just definitions, but unless there be some sort of protocol, I'm not sure if it's anywhere near where we would talk about it being a treatment protocol, even though, like I'll tell my clients, spoiler alert, exercise is good for you. And, in terms of some of the supplements, again, it's sort of a mixed bag of what works and in what combination. There are some things like the concept makes sense. But again, and dietary restrictions, apart from people with documented food sensitivities, food allergies, and again, going back to, both of us being clinicians, hey, if you take this food out and you're doing better, keep doing it. What works for you, even if it's, because, when we're talking about the studies, we're talking about overlapping curves, and not everybody gets better with the studies. Even the effective ones, there's a lot of people who might need more, or just like with medications, partial response or can't manage the side effects. And psychosocial treatments have side effects. The cost, the inconvenience, the time investment, things like that could be deemed side effects that could interfere with their use.
Yeah, and I guess with a lot of these non-medication strategies, I worry about the problem of not necessarily science that disproves them, but simply a lack of studies in the first place. So I'm not aware of how many studies have been done to test how well exercise helps with ADHD, or how well certain diets help, or certain supplements, importantly.
Right.
I tend to take quite a common sense, pragmatic approach with these things. We know that exercise releases a lot of the same chemicals in the brain that medication would, chemicals like dopamine or noradrenaline. And anecdotally, patients very often report that exercise helps with their symptoms. And you can certainly understand how it could help with relaxation, impulsivity, sleep problems, restlessness. Yes. And so it goes with nutrition. There might not be a clear food sensitivity or allergy, and yet clearly we know we can have a common sense approach to what kinds of diets are more likely to support the functioning of the brain, and what are less. And so I tend to, there are some resources I signpost patients to, but in general, I generally counsel patients to avoid foods that are like overtly junk food, and try and, go to the common sense, good nutrition, the protein, the good mix of fruit and vegetables, etc. And that's the kind of advice I give around that. Diving deeper into the psychological role, which of course this is what you specialize in, what does CBT for ADHD look like, and how does it differ from other kinds of CBT or more generic CBT?
That's a great point. And I want to start that with citing a study that came out of the UK, again, still within the past year. But what it was, I think I have the number right, 46 individuals who had completed cognitive behavioral therapy through the NHS. And they completed a course of cognitive behavioral therapy for adult ADHD. And all 46 completed surveys, and I think 10 of them were selected for interviews about their experiences. And the results were awful. People saying I felt worse at the end of treatment. It didn't seem like my clinician knew what they were talking about. They rigidly followed the protocol, whatever it was. And what that speaks for me is, and let me finish up, but one of the interviewees had described that they had a clinician, their therapist was very familiar with ADHD, and they described the treatment as transformative. I understand my brain and how I can make it work without, comparing myself with it. I can find my own way and, fashion things my way. And I'd have to go back and look, but my assumption is probably some very well-trained cognitive behavioral therapists for anxiety, depression. And I think if I didn't put it into the blog, I would raise my hand and said that could have been me if I had not accidentally ended up. So these are probably very good therapists, but it's a little easier going from cognitive therapy or cognitive behavioral therapy for depression to anxiety and some other things. Whereas ADHD, if you're not familiar with it, even apart from making the diagnosis and the assessment, but how it affects lives and the things that, I know I should start earlier, but I still procrastinate. Things like that, the performance problem rather than the knowledge problem. And if the CBT is not adapted to that, we have evidence about, this study is evidence about what happens. So this is a little aside, but, this is why ADHD is still a niche specialty. And later on, if you ask me the question, well, where do people go to find somebody who does this? It is still hard to find people. At least my experience in the US, I would imagine in the UK, at least what I remember, some reports about the waiting lists and, things like that. So, I mean, there are people there, but there's only so many. So all that going back to how does it look different from, say, cognitive behavioral therapy for depression or anxiety? And I say this respectfully, the feeling good approach, the mind over mood approach, which are excellent. Those books change lives and those approaches change lives. But with ADHD, I think it's understanding ADHD and the executive dysfunction, focused, like what I describe my approach, I say it's very implementation focused. So there are still things like not procrastinating, starting earlier, but like with procrastination, I think part of it is reverse engineering procrastination into all the different steps that go into it. Some of it is, I don't have a plan for what I have to do, so it's probably never going to come online, or I'm never going to want to do it. Or even if I have a plan, I might think myself out of doing it. Oh, this is too much. I'm no good at this. Some of the classic CBT stuff, the emotions, I don't feel like doing it, and escape behaviors, escape avoidance, which is the most common behavioral reaction in adulthood. Now, with those things, it's also having a template for, okay, if we can break down procrastination into smaller steps that are actionable, doable, and you believe you can do it cognitively, and you can tolerate the likely uncomfortable emotions that go along with it. I don't feel like doing it, which is also the motivational feature. At least now we have a couple different intervention points. It's not just start earlier, start earlier, start earlier. That can be customized. And very often clients, going back to the clients know best. And, even some of the strategies I come up with, I've learned from clients and just share them because the creativity that comes from workarounds for ADHD. But now if you have a couple different points, people might have their one or two go-tos. Okay, if I can do this and this, I'm more likely to follow through with my plan or use the planner or whatever the goal is. And these tools are usually as a part of some sort of coping domain or area of difficulty. Then I can be more on time arriving to work or to school or to class, or getting ahead or at least an earlier start on projects I have to do for work or school or at home, or things I have to do as a parent or running a household or other things, including self-care. So in a way, this sort of executive functioning scaffolding and the time management, and again, people can be creative and find their own ways, but usually it involves some sort of planner system, digital or otherwise. So I think that's something that's maybe not foreign to cognitive behavioral therapy, because there's activity scheduling for depression, and somebody who's depressed won't feel like doing anything. And even if they come up with a schedule, they may not do it, but that's part of, the behavioral activation. And likewise with exposure treatments for anxiety, I really don't want to do this. And, it carries over with, some of those tips and tools, in addition to the fact that those are probably the two most frequent coexisting diagnoses with ADHD, some form of depression or anxiety, it maybe even sub-threshold, but it is hacking some of those things. But it is the customizing it to ADHD. And I mean, my friend and colleague and world expert Ari Tuckman has said these are the Ramsay grandmother rules, because I say these are the same thing our grandmothers would tell us. Break a large task down into small steps. But I think with ADHD and the working memory difficulties where we hold on to information, which also guides behavior, these are the things where the steps are slippery and they fall out. So maybe even having externalized lists and recipes for what we're going to do. That's why externalization of information in a planner or a journal, or and again, sometimes it is writing down the steps. And I see it in some of the adult ADHD client manuals or the coping workbooks, if you will. It's like having the steps out there. Here's what to do, because and again, this is not meant to be diminishing anybody, but it's personalizing that. Being able to see these steps, I'm more likely to do them because I don't have to spend as much cognitive energy figuring them out, or fits and starts and things like that. Now, that's just one example about how ADHD has to be customized, and probably why in that study I mentioned, so many people had a frustrating experience because they were probably getting classic cognitive behavioral therapy that would help a lot of other people, but without it being customized, that's where it fell apart, at least in that study.
Yeah, that makes a lot of sense. And I think I love the stairs are slippery analogy. I've never heard that before. Because when I think about CBT, typical CBT for anxiety or depression, it's predicated on the notion that if you have a basic understanding of how your mind works, how your emotions, thoughts, and behavior kind of interact with each other, once you have that map, then you just have to follow certain steps. So thinking about, let's say, mild to moderate depression, someone may, when they feel their mood is low, that's the feeling, they might have negative thoughts. And between the mood and those thoughts, their inclination, their behavior might naturally be, well, I'm just going to stay in bed all day. Through CBT, they realize, oh, actually, by doing that behavior, all that does is also further decrease your mood, further cause negative thoughts. So you have to kind of short circuit that system by doing a different behavior, often the exact opposite behavior to what you're inclined to do. So if you feel the low mood coming on, what you do is you make sure you get outside, get some sunshine, speak to some friends. You might not feel like it before. You will feel a lot better having done it. And then you short circuit that system. That works great for depression, works great for anxiety. I see the problem you run into with ADHD, because one of the core features of ADHD is an inability to translate thoughts into behavior, what we would call executive function in the first place. So the stairs are slippery, as you said. So I can see that having a form of CBT where you really, really focus on what are the obstacles that people face between thoughts and behavior, or emotions and behavior, to a high level of granularity that you wouldn't have to focus on otherwise, that's like core to the treatment, I guess.
Yeah, yeah. And one thing I'll add with that, this is where I also think, and there's a lot more, and thankfully so, discussions about the therapeutic relationship, the therapeutic alliance in cognitive behavioral therapy, because I think I think it's always been there, but when cognitive behavioral therapy came on the scene, like Dr. Beck started his work in the 1960s and 70s, and then the late 70s is when the depression manual, I guess there was a depression book, like I think it was 72, but that before the manual came out, but it was more about like the technique, the manual. But I especially with adult ADHD, that connection, somebody who gets it. Because usually, and normalize, like one of the reframes I find very helpful working with clients in CBT is normalizing, that, there's going to be slip ups. And even with the person that you see, your friend, the student, or a coworker who looks like they have it all together, and well, they're still using a planner and they procrastinate sometime, or even if they get their homework done, they don't want to do it. It's still somewhat of a struggle, not as much, but it's that dimensionality. It's in the ballpark, but this is something it might take a few more steps or explicit steps here, but being able to hear that from somebody who goes, I don't think any of the therapists would have done this, but some of the messaging that many individuals with ADHD get, it's sort of like, why don't you just get started? Or how hard is it to pay attention? Or, it's due in a week. Why aren't you starting now? Or all these things. And, it's, being able to sit, not that it's, oh yeah, there's nothing you can do. Let's just have a pleasant meeting. But it's like, hey, let's find the step that's right for you. And it might take us a little while. But we can try things on, for size. It might take a little while, but we can get there where it's at least better in some way.
Yeah. Going into focus more, obviously a core problem with ADHD is difficulty focusing one's attention on something specific for a sustained period of time. What are your thoughts on the malleability of focus? Is focus something that we can train? Can someone with ADHD improve their ability to focus, train it like they would a muscle? How do you think about this?
It's a great hypothesis. And I think what we're talking about here is like focusing in day-to-day, directing focus and moving it around and, the focus, the attention allocation, if you will. The neuroplasticity, my hopeful side would say, it would seem like there are things that we can do that can at least make it better. And again, I'm usually a little bit just more conservative on this. The example I use, in a session with me, it's not going, okay, we're going to focus on your focus today. Look at my nose for 10 seconds, take a break. Let's see if we can get it up to 20 seconds by the end of the day. But I think focus might be a side effect, at least as with your great question, how I'm thinking about it right now, as part of the overall, well, what is the flow of your day like? Also the rhythms that come with focus and energy, about which there is some evidence about this, maybe not specific to ADHD, but how we have rhythms in the day where maybe earlier in the day we have more focus and there's a mid-morning, later morning dip, and then it comes up again, maybe later in the afternoon, then down. And with ADHD, that might be more variable all the time, maybe. But it's playing to your strengths, including things like if you tend to be more focused in the morning or right after your medications activate, for lack of a better phrase. What are things you want to do during that time of day to take advantage of this? And when you're at a lower ebb, what are some things that might be better for? Things that might not be as cognitively demanding, lower cognitive load, but maybe still work, or heaven forbid, a break or exercise or other self-care, things that can also help replenish our cognitive resources. So my first reflex is, how does it all fit together? Focus being another resource, just like energy. And because thinking is hard work. And that's the other thing about ADHD. Usually, it seems like, for my money, procrastination is probably the most common, but there's a lot of thinking that goes into procrastination. I should do it now, but I don't feel like doing it. Let me do this other thing and then I'll get to it. It's like all day. And that is tiring. And the mental is physical. What is the brain is like 3 or 4% of the body's mass, but uses at least 20% of the energy. I sort of see it as another resource, a time resource, if you will. This is the personalization of one's day to the degree that we can. School and work doesn't always cooperate with that. As well as things like interaction with social media or technology. And I like the phrase, the choreography of things. I think with that comes, getting the most out of the focus available. And also things that I would say, including getting engaged with something. Now, this could be a have to, like a project for work or school. But usually people say, I feel better getting something done. But then if there are things like exercise, good health practices, including things of interest, it could be, dose-dependent video gaming or whatever somebody's into, or exercise, things that can, improve the overall brain health, but also maybe, help with focus too. So that's a very long-winded. I think there are things that we can do to, one, make better use of our resources, our cognitive resources, interacting with the environment and respecting our flow over the day, as well as having downtime which I think is underutilized. And that's part of what sometimes gets lost with ADHD, because spending all day not doing something, it's not like somebody goes, I'm taking the day off, I'm going to take care of myself, and then I'll come back tomorrow. No, it's all day not doing it, but also maybe not doing the fun things, including exercise or other things. So I think it's that overall picture, and that, focus is one of those crucial resources. So it's a long-winded, I think there are some things that can be done, even though, like, if somebody's coming to me, this is an example I use with clients, and they say, no, I'm on time with things, for meetings, I hand in things on time, I'm not pulling all-nighters, but I really have a hard time reading text. Not text, like any text. It could be online books and comprehending what's going on. I'll say, we can talk about your attentional vigilance and the, when you do it, how long, what's your attentional endurance. So you don't try to make yourself, you read 30 minutes at a time and take breaks. But that would be something more, I think, the purview of medications, where that sustained attention on, cognitively demanding tasks. I wouldn't be all or nothing about it, because again, if somebody can't take medications, but there might be the reality of, maybe reading 30 minutes at a time, it might take you longer to get through the chapters or what you have to get through, but, finding something that works for you with adequate, breaks and restoration.
Yeah, I really like the point about how to choreograph your day. I mean, as someone without ADHD, I've become way more conscious about how I might plan certain aspects of my day based on how well my mind happens to work at that time of the day. There's a time of the day where I'm going to slot in my hardest, most concentration-laden work. And then there's a time where I'm going to do my most sort of mindless admin, and there's everything in between. And I think mastering that dance is very important. I think more on the focus issue, I have noticed a lot of people's experience with ADHD is when they try and focus on something hard, and there's a rush to try and get it done as quickly as possible. And then there's a quick frustration. There's a sense that this should be way easier than it is, or I should be able, negative thoughts can come in with that, like, I should be able to do this. This is a sign of me not being intelligent, all these self-critical thoughts, etc., etc. So something I found really helpful when I'm counseling people with ADHD psychologically is, if they're engaging with something difficult, try and engage with it with a much, much more relaxed manner, much more of a low bar for success. I'm more just saying, okay, I'm going to engage with this for 10 minutes or 15 minutes. I want to do my best, and then maybe see where it becomes a little bit uncomfortable. Maybe go slightly beyond that, and then stop, which is exactly what you would do if in another life, if I became a fitness trainer. That's what you would do with weights, is you wouldn't say, okay, everyone else seems to be able to bench a couple of 100 pounds, so you should also do that, go and bench a couple of 100 pounds. You injure yourself. Rather, it would be, pick a weight that you can manage and do it for not very much, 8 to 12 reps until you get a bit tired, maybe push slightly beyond how tired you are, and then stop and take a break. You do that, 9 times a week, and your muscles are going to grow. And I think, at least very anecdotally, that's what I've seen with my patients and clients, is you take that somewhat more, it's a subtle thing. It's almost like a mindfulness thing. You take a slightly more relaxed stance to what you're doing. Try not to rush to the end. Try not to have a lot of rigidity about the outcome. And then I found that their focus does actually tend to improve over weeks and months. So it's a long process, but I've found that can happen.
Those are excellent points. I 100% agree with that. And again, it's sort of, sometimes popularly known as chunking. And it can be, sort of like, well, I just want to get it done and out of the way, which is understandable. But no, exactly what you say. It's breaking it down. I would call it a bounded task. The example I use, somebody drops you in a large body of water, and you're told swim. And there's no shoreline or nothing to give perspective. You don't know how to swim, or you're going to tire yourself out. You're going to sprint or whatever. But we're creating shorelines so we can calibrate. And that could be time-based. Hey, work on it for 10 minutes. See how far you get, then reassess. Or it could be a task bounding. Write for 100 words. Just get 100 words down. See how you're doing. And that sort of incremental pacing and seeing like, okay, I can go another 10 minutes or another 100 words or whatever it is, that building up to, rather than setting, I have to do the whole thing, which is vague and non-specific and can be overwhelming. It's like, swimming in a large body of water, but not knowing how far it is. But once we know how far it is, like you said, like with weights, I know I can do this. It's tough. Or 5 more minutes on the treadmill, we can adjust our expectations because we have that perspective. And a reframe I go to a lot, I call it enoughness. I have enough focus to keep going. And it also gets at a sense of self, like, you know what, even though I'm not great at school, I'm enough to get through. Or I don't like it, or it's hard, but there's enough that I can pass or do a good job. And this is putting aside, just to make sure I cover it, every now and again, you might have had this, somebody at university who eventually decides, what I want to do, I don't need to be in school for. I'm really more passionate and better at this. And this is something I can learn by example or get trained in. Or, it comes to mind a young man I was working with in college who had a wonderful summer job as an automobile mechanic and working on special cars, and like almost like an apprenticeship. And he learned better that way. And I don't know about you, but my mechanic gets enough money from me. It's not a bad job. And especially if you enjoy it. And think about it, it's problem solving. I'm thinking some mechanics I had, they were like surgeons with a car, how they figured out and diagnosed the problems. So these are not just, that sort of skill doesn't always require school. So sometimes somebody's in the wrong situation, a mismatched situation, but bringing it back. And even something like that, it might be somebody needs to take a break. Okay, I've worked on 3 cars in a row. I need to take a break because now I'm getting frustrated. I'm missing details. I need to respect my endurance. And an analogy I use, and I'm going to use, and you will appreciate this, the correct version of the word. I played football for many years, and not American football, as you can see, but a good footballer finds their rest on the field. And it's sort of that pacing, running for 90 minutes, and nobody sprints for 90 minutes. But how do you find the pace, that choreography again, to make it through the whole match?
Yeah, and it's so funny how all of these skills, I think they really apply to ADHD, of course. And I think they also apply to anyone that's pushing themselves beyond their boundaries. So even high-functioning individuals I've worked with who don't have ADHD, they just really want to push it to the limit and be like, how successful can I get? Because both groups, whether you have ADHD or you're trying to get really, really successful, you're pushing at the edge. Funnily enough, they tend to require similar strategies.
Yeah. And even folks day to day who just start feeling overwhelmed and maybe start procrastinating. Like I've had colleagues say that they will sometimes recommend, ADHD coping books for their clients with anxiety or depression because it gets at some of these things and breaks it down in a really user-friendly way. So that's another reason why a lot of people say, well, doesn't everybody have ADHD? These, 2 quick thoughts. One, these ideas could help anybody. And second, there's a concept known as universal design. And I got this on a book about like learning differences, but it harkens back to architecture, making buildings accessible for everybody. So that's like having ramps and, in addition to stairs and other ways to make it useful, but how this idea got carried over into, say, education and some things that are more commonplace now, like rather than if in grade school, students have a big research assignment. Okay, this is due in a month, and here's what you have to do. That didn't work for a lot of students. And even the ones who were able to do it probably had help from their parents. But nowadays, and it started with students with learning differences, graduated deadlines. After the first week, bring me your proposal. Then bring me your outline, then bring me your first draft, second draft, and then hand in the final project. But now that is not 100%, but my experience over the years is that's a lot more of how assignments are offered because it helps everybody rather than, I got this big assignment, where do I start? It gets broken down, part of what, it's part of what executive functions do. But if we can lighten the load, then we have more energy. Anybody has more energy for other matters. So it helps everybody, but it's essential for individuals with ADHD.
Yeah. Something you said earlier where you had an experience of a client who was particularly good at practical things, mechanics, That's something I see all the time, and it's widely reported anecdotally that people with ADHD are often really good at hands-on tasks, sports, things like that. And that feeds into this wider conversation about ADHD that is something like, is ADHD a disorder, a condition, or is there a small, 5% of the population that are adapted to a very different kind of world than modern society has developed into? So is it that people with ADHD have a disorder, or do they have natural strengths which were really advantageous in the past but are less advantageous now? Would people with ADHD thrive in an environment with, constant different stimuli that need to be paid attention to, rapid switch of attention, rapid novel tasks that are completed quickly, tasks that are hands-on and practical as opposed to abstract and prolonged into the future? There's this real conversation around autism as well, which is similar. Is autism a disability or a difference? And I think you can have that debate about ADHD. Is ADHD a disability or a difference? What are your thoughts on that?
Well, this goes back to that study I mentioned before about dimensionality, because that would say it's a difference, it's a variation among, a bell-shaped distribution. I know executive functions are more complex than that, but distributed within the environment, and that's where context matters. This might be a little all or nothing, but a line I've used before is ADHD is not environmentally caused, but it is environmentally bound, like the setting. That's sort of what we all do. We have these skills and abilities and the things that are not so much. So like the car mechanic, I'm not the most mechanical guy. I'm a pretty good problem solver, but I think I found a pretty decent niche with this. And likewise, somebody else maybe wouldn't be able to stand my day-to-day job, but something else that I couldn't fathom they can do. But with ADHD, it's an interesting question. It's something I ponder a lot. That's why I like the dimensionality. Now, within dimensionality, there can be some things at extreme ends, like extreme underweight and extreme overweight. I think there is an end of it. It's a style, it's a profile that sometimes requires some support to fashion a better fit or to find what's a better fit. But you know what? There's also some elements with it. An argument could be made. This stems from the mismatch, if you will, that, the mood, the anxiety, the somewhat increased risk for, suicide attempts and completed suicide, and like the health issues of like increased likelihood of smoking, other poor health practices that at least in some research has said by age 27, a health profile at age 27 on a group of children with ADHD tracked into adulthood. Now, these are often changeable behaviors, but that they're on track for a reduced estimated life expectancy of more than a decade, based on the health profiles at that mid-20s age. So I guess I guess maybe as a cognitive therapist to me, I'm hesitant to totally go like it's all a style, because it can be associated with impairments. And again, these are social constructs about, well, then, protection under the Americans with Disabilities Act type of thing, in the U.S. at least. But I think within society, and I guess more the work, that we do in our field, how we frame the treatment and how frame the approach. Yes, in the U.S., there might be certain requirements that my clients who submit their receipts for my services into insurance company have to put down that are DSM and whatnot. But every session, I'm not saying, hey, our agenda today is we're trying to reduce your disorder. It's like, what do you want to do? How can we help you do what you want to do? Right of self-determination and betterment, not any sort of, you have to contribute more to the gross domestic product. However you do. I got asked this question one time. It's like, I think it was from somebody who had a bad experience with CBT. And it's like, well, what are your goals? I said, well, it's the client's goals. It's like I'm there to help them and to fashion them into doable goals if it's maybe a little too much too quick. And it just seemed like they might have had, it might have been like that study I mentioned before where somebody got into a really strict classic CBT that wasn't adapted. So it's really, hopefully meant to be humanizing, empowering. What can you do? And personalized. And, this too. And the incremental improvements. It's really important to acknowledge those. That, as, hey, you're more on time nowadays, or your grades are a little better, or even before the grades, it might be you're finishing assignments and handing them in a day early or hours early rather than minutes early, or, sadly before, maybe minutes or hours too late, which it would affect grades more than any of the quality of the work. So those things, I think, and it's also that dealing with that less than mindset. Oh, everybody else is better than me, or they can do this better. What's wrong with me? And which can have manifestations. And we could argue whether that's a failure schema or an inadequacy schema. It's probably the same thing. It's like that not just the messaging from others, but just the social observation that we all do. Oh, everybody else gets better grade, or I'm always late, or I forgot to upload my assignment, or whatever the case is. Sometimes it's the natural calculus that we do, and it's sometimes not wrong, but that's where the understanding of ADHD and then how we approach it gets personalized, and it becomes more that enoughness and empowerment, hopefully.
Yeah, it's a really delicate balance clinicians have to strike with ADHD. How do we help people to understand, target, acknowledge certain problems, while at the same time empowering them that, hey, your reality is malleable. There are things you can do. This doesn't have to limit your success, and can come with natural strengths that we've described. Because, a lot of the criticisms of ADHD diagnosis, and there's a lot of talk of overdiagnosis of ADHD, is of course that by giving someone a medical label, they have something they can use to justify kind of restricting themselves, or something that encourages limiting beliefs. I have ADHD, therefore I can't. And obviously, as clinicians, we want to avoid that, because you could say that's a form of medically induced or iatrogenic harm, by giving someone a label, I think, in the wrong way. It's kind of a prison you're making for them. You're saying, you can subconsciously imply they're limited in some way. We definitely want to avoid that. At the same time, if someone's had persistent set of problems throughout their whole lives, it can be very invalidating to say, actually, this isn't a real thing. So quite a delicate balance we have to strike.
Yeah, I've probably heard it said different ways, but I remember Alexander Philipson in Germany, a psychologist, a leading leader in the field, has modified dialectical behavior therapy for adult ADHD. Was a lead researcher in one of probably the biggest, psychosocial and medication and randomized crossover design in history. But she said about her approach, it's balancing acceptance and change. Some of it is acceptance. Okay, every now and again, I'm going to get off track, or I'm going to procrastinate. But I can bounce back and get back on track, which is also the name of the game in CBT for adult ADHD. But, going back to some things you said, again, one of these phrases that's out there in the field that I think we all borrow from each other is, ADHD is not your fault, but it is your responsibility. And even if it's and a point I'd like to make too, though, adding to that, even if it's your responsibility to manage, that doesn't mean you have to do it solo. It's reaching out for help. It's, maybe working with loved ones, and, even within a household. And accommodation can be, oh, I keep forgetting to keep track of the bills. Can I hand that off to you, and I'll be in charge of, taking out the garbage and the recycling each week, or, other ways that, can be a win-win, for somebody with ADHD, but also somebody else who goes, yeah, I'd rather take care of this chore than do that one. But all these things and maybe are going on out there already. And and there can be that view that, oh, these are people looking for an easy way out. Some of the hardest working people I've known are the ones that I sit with who have ADHD, because as one of my colleagues once said, it often involves working twice as hard for half as much, like procrastinating all day and then working on it at night. They probably worked 18 hours that day, getting the one thing done, which is as tiring as it is for anybody else. But that's not somebody looking for an easy way out. That's somebody struggling to get it done. And, there are things that we can do and changes to be made, that, a part and parcel of a typical profile of ADHD, but don't say that person's not working hard. We're just trying to help them. Again, it sounds clumsy, but utilize resources, choreograph so you can enjoy time with your family, doing your hobby, doing things that you enjoy that are enriching. The want tos, which can also fall by the wayside due to disorganization. Oh, I missed my yoga class or whatever. At the same time, taking care of your roles and responsibilities, whatever they may be, but also not that those can also be rewarding, even though they may not be fun. That sort of like goes back to Dr. Beck and behavioral activation or activity planning, mastery and pleasure tasks. Pleasure tasks are things you do for recreation or for fun. Mastery are tasks that you have to do, and maybe you feel accomplished getting them done. Or if not accomplished from an existential standpoint, it just feels good like, okay, homework is done, the garbage is out. It's nice getting them off your plate.
And the worst are the gray tasks. That's what I warn people against. It's not the pleasure tasks.
Very good.
It's not watching your favorite show after you've had a good day. It's not taking out the garbage. It's that gray task. It's watching a YouTube video about a subject I already know quite a lot about, or watching a movie for the 20th time because I'm delaying fill in the blank. The gray tasks, when I do some coaching with people, and when I do coaching, the gray tasks are the ones, that's where you can find the most time. If you want to start a business or learn a new hobby, you have to target the gray time.
Very good. That's an excellent reframe. Yeah.
You wrote a really interesting blog post about social media and ADHD. Specifically, social media is now increasingly a place where people find out about ADHD and maybe find out they fit a lot of that symptom profile. A lot of people come to assessments being like, I was on TikTok or Instagram and a couple of videos came up about ADHD. Inherently, that's worrying to the clinician's ear. It makes us worry about overdiagnosis, over-medicalization. At the same time, people are finding out in their 30s, 40s, 50s, 60s, perhaps that they've had an undiagnosed problem and finally are getting some help for it. What do you think about social media as a viable educational channel for these sorts of ideas?
I think that blog was specifically associated with some research on TikTok. And there's actually been more recent research within the past couple months, I would say, supporting that, where just how the vast majority, I think it was 79% of TikTok posts were misleading. And only the rest was viewed as credible, and those seem to be upheld. So, but going back to it, it's very interesting because there's a lot of stuff that is wrong. Things that just are not viewed as symptoms of ADHD, or oversimplified views, or personal testimonials. But that's the tricky thing, because the personal testimonials in general, even if it's accurate, are the most believed by consumers. And this is human nature. We hear the story, and that's often how family members of somebody with ADHD learn about it. It's like, oh, I know somebody with ADHD. Now this makes sense. When you think about it, most doctor's visits, let's call it that, and broadly, start with self-screening. I'm not feeling well. I better call the doctor. Or this thing isn't going away. Or I've been depressed for a long time. And, doing an online search, should I be worried about this spot on my arm? So starting with just maybe not the best, most thorough research, but then following up. So I think one, in terms of the overdiagnosis, social media is a screening tool. And just like a screening tool, I'm not saying it's the best one, but it's out there. Second, even with established screening tools, they are designed to cast a wide net. Let's just say it's for depression, diabetes, whatever. There's going to be some things in there to make it general, to say, we're going to catch some people without diabetes, without depression, but we want to make sure we catch more people.
It's okay to get a false positive,
but we want to get more true positives. And that's what a screening is. Come in and say, no, it's not that. You're fine. Be on your way. So that also brings it to like the evaluation of ADHD. One, having enough people who can do an accurate job, both catching it when it's there, and not getting it when it's not there, sensitive and specific. And even within that, though, it's being able to tell people, all right, you endorsed a lot of symptoms of ADHD on these rating scales, but after interviewing you and these other things and the requirement for impairment, I can't in good faith call this ADHD. It might be depression. It might be anxiety. The very first person we ever evaluated in our Penn adult ADHD program, we sent off for a sleep study because we think it was apnea. He hadn't had a full night's sleep in a long time. So that looked a lot like ADHD, but it wasn't. And making, people who go through the whole thing, including verifying childhood onset. There's a lot of steps that will probably come through in the forthcoming US guidelines that are probably already out there in the NICE guidelines and European guidelines. But there's a lot that goes into it. So if we think about it as screening, because one, even if, there's a lot of people going around saying, oh, I have ADHD because I look like that person on TikTok. That doesn't mean they have it or that they're prescribed medications or anything like that. But there are some other very well done, well constructed studies where ADHD is identified, which this is valid, or at least to do research, has and one that reported on the high rates of, I think it was adolescent boys with ADHD in the US, was asking, has a healthcare provider ever indicated that your child has ADHD? And that could be a provider who says, could be. You should get them checked out, or here's a prescription or whatever. I'm not saying it was necessarily that glib, but somebody could say, yeah, they said it could be. And then I forget what the numbers were in that study, but it was some more exorbitant number that most experts would say, yeah, it's probably closer to like 7 or 8% rather than whatever it was. I think it was in the teens. The mid to upper teens. So it was, got a lot of headlines, but, and rightfully so, because being aware of, we need more clinicians trained, specializing, or at least competent in adult ADHD. One point I made, and I want to give him credit, David Goodman in the US, an ADHD expert, physician. It was the National Comorbidity Study in the US. Looking at the range of depression, anxiety, schizophrenia, ADHD in the early 2000s. And David, on one of his slides, showed that at the time, the number one psychiatric diagnosis was depression. Number 3 was anxiety. But number 2 was adult ADHD among adults. And, with the more recent Center for Disease Control in the US, their first study of adults with ADHD that found this time number 1 was anxiety. Again, number 3 is depression, but again, adult ADHD was number 2. So this would be like going to your family doctor saying, I can help with arthritis and hypertension, but not just I don't specialize in diabetes. I was not trained in diabetes. So that's sort of what we're talking about here with adult ADHD. It's not just, it's not what I do, but I'm competent. I could evaluate and then refer you for treatment or whatnot. No, we don't even have where somebody says, this sounds like a cardiac problem. I want you to go see a cardiologist. Yes, there are some screening scales that can be used, but adult ADHD is still not part of adult psychiatry, adult clinical psychology training yet.
Yeah, it's quite siloed.
Yes, and it's a niche specialty where even if people are manifesting, it's a gamble whether they're going to get specialized care.
And do you think any of the concerns about overdiagnosis are valid, as the rates of diagnosis seem to increase in the Western world? And I do understand also that the prevalence of ADHD, as far as I know, in the US is higher in the UK. Is overdiagnosis something that concerns you at all?
Yeah, because one, and this could be anybody, this could be a well-meaning physician, even an expert, who they go, with the presentation, this looked like this, but then other information comes to light, or whatever the case may be. So just in terms of practice, there's going to be some misdiagnoses, including underdiagnosis or misdiagnosis. I think the rise, now there can be ridiculous rises, but at least within the US, adult ADHD was the number one increased diagnosis over the pandemic years. Part of that due to access. People could virtually reach out and find people who were competent in and experienced with adult ADHD, and some of the licensing restrictions of practicing across state lines were reduced, and the virtual care increased access, especially for women, because that was the number one group. 61% of women in that CDC study I mentioned were first diagnosed in adulthood, whereas we're like a little under 50% for males. So that's been an underrepresented group. So I still think we're in a correction phase of, it for so long being undiagnosed. And again, we're talking about some of the actual prevalence numbers from research, but there's a lot more. It feels like there's a lot more out there because there's a lot more people saying they have ADHD or claiming it. So, but yes, it is a concern because we want to be right, because even in cases where it's not ADHD, and I've had a couple, already this month where it's like anxiety or whatnot, but getting to people veered to the right care, it's important, hard stop. But yeah, so I think at this phase where we're at, it's a benefit that ADHD is more on people's radar screens. I think there's probably more use, and this is still something that some of the professional societies associated with ADHD are working on, like even primary physicians, family doctors doing screenings and maybe more likely to refer for services. But now I think the best protective factor we could have is better education in our clinician training programs, so that we can make sure the numbers are accurate. But I still think we're in a correction phase. A lot of the studies, it's still, like I said, that 8%. That's higher than the 3 to 5% I had been citing for years. But I mean, concern about overdiagnosis and accurate diagnosis, 100%. Better training, looking at other things, and also sometimes where it might be a complex mixture, where ADHD might be on the scene, but it's more like the addiction or the depression is more prominent, or the untreated bipolar disorder. I think we're also at that phase where it's out there, and the training and being more on guard for that, and being, training clinicians to be able to explain why it's not ADHD when it's not the case. So I think we're, moving, and, ADHD is on the radar screens more, but yeah, we're probably at that point where we're looking for, still being diligent and calling it ADHD when it is, but being, looking at, as always, and I would have said this before, just looking to be accurate in the diagnosis, and to make sure people are getting the recommended protocols, because that's probably where a lot of the misdiagnosis happens, where it's, I say this respectfully, with doctors trying to work within a 45-minute visit and maybe having a hard time or not having access to scales to use or whatnot, where, sometimes it's people trying to do the right things by their clients, but, making do with, things that just aren't going to meet the standards.
And lastly, because we're running out of time, but lastly, in your experience, when it's not ADHD, what is it most likely to be? So what are the most likely differential diagnoses in your experience?
Mood or anxiety disorder. And, and sometimes things like, and this falls outside the realm of that, but, sometimes it can be an obsessive compulsive disorder, where the distractions are the obsessive thoughts or the compulsive worries. Some trauma related, especially if the trauma comes later on and you can go back and see whether there was pre-existing ADHD, but they can layer on top of one another. Or, situations where it was obvious that there was no childhood onset of symptoms, and not due to circumstantial situations like an insufficient school system or other things where there wasn't an adequate way to evaluate childhood onset. And another thing is where, even with those things that can get in the way of fulfilling life roles, it doesn't seem to be associated with a broader executive functioning difficulty. There's intact executive functions, like you said, with the cognitive therapy for depression, being able to, can you do the experiment? You're depressed, but let's do pleasure predicting. How much, if you go to the movie with friends, what percentage out of 100, how enjoyable do you think it'll be? 30%. Can you compare that with your rating afterwards? It was more like 70%. I liked it more than I did. That requires some executive functioning that intact executive functioning that can maybe be weakened by mood issues, but still they're sufficient to do the exercises. So the absence of the executive dysfunction problems during inter-episodes for mood or anxiety situations is another tell for me.
Well, Russell, thank you so much for coming on. I'm sure people will get a lot out of this episode. Where can people go to find out more about your work?
The easiest place, and where you might be getting this recording from, but my website, and it also has a contact form if you want to get in touch with me, www.cbt4ADHD.com. You might have this. Some people hear CBD and they get really excited. No, CBT is in cognitive behavioral therapy, 4ADHD.com.
Perfect. We'll put a link to that in the description. Dr. Russell Ramsay, thank you so much.
Alex, it's a pleasure. You're doing great work here, helping a lot of people. Happy I can do my little piece to help out.